Hi, I'm Emily.grey, and today I'm going to tell you about EMTALA and mental health. Now, this isn't really an EMTALA basics course. I'm going to assume that you kind of know the basics. I'll give you a real brief overview. It's more about how EMTALA applies to things like psychiatric hospitals and other mental health facilities. Before I get to the brief overview, I'll tell you a real quick story about me. I love EMTALA. I think it's really interesting. I started reading this stuff when I got out of law school. I just, read everything I could find on it. And it took me about 10 years of talking on this topic to figure out why I think it's so interesting. I'm the child of an OBGYN. So as you might imagine, when I was little, we'd be doing fun stuff, opening Christmas presents, going to movies, and Dad's beeper would go off and he'd have to go to the hospital. And I think when I got out, it made me happy to know he was legally required to do so. I was telling Dad this story, and particularly because some of his buddies are in my audiences every now and then. And he said, well, Emmy, that's a nice story, but when you were little, we didn't have EMTALA. And I said, all right, Daddy, I know. EMTALA went into effect in 1986, and we're going to pretend that I was little in 1986, just like we pretend that my hair color is real. So get with the program. So that's my story about EMTALA and why I like it so much, and what I hope you remember is that it was effective in 1986, and not that I wasn't little then. Okay, so brief overview, application of EMTALA. We all know that it applies to emergency departments, but what's more interesting for psych facilities is that it applies even if you don't have an emergency department, where a third of your visits are for emergency medical conditions, for ambulatory patients who show up with no appointment. So even if you don't have an ED, EMTALA can still apply. And in fact, in Louisiana, our state law says if you're licensed as a hospital, EMTALA applies to you, and that's the position our regulators take. There are some exempt entities, for instance, ambulatory surgery centers. Also, what's interesting for us is that off-site campuses, which often we see psych services provided off-site, or particularly those IOP, those intensive outpatient programs, it generally won't apply there unless you're going to have that 1/3 test that makes it apply. Also, important to know that EMTALA is not a federal malpractice statute. There is a difference between whether a hospital has met its requirements under EMTALA, the screening and stabilization and transfer, and whether there was a breach in the standard of care on the other hand, which is more of a malpractice determination. We'll see more of that in the cases at the end of the presentation. Okay, brief overview of our requirements. When an individual shows up with an emergency medical condition or something that appears to be, the hospital is obligated to provide a medical screening examination within their capabilities to determine whether there is in fact an emergency medical condition. A qualified healthcare professional is supposed to conduct this. If it's not a doctor, it's supposed to be in the bylaws. Okay. So if the individual has an emergency medical condition, the obligation of the hospital is to stabilize and/or transfer. For psych purposes, there is no question that the emergency medical condition includes psychiatric disturbances. That is clearly included, so that's something that has to be treated under EMTALA. If an emergency medical condition exists, you determine that through the medical screening examination. The hospital's obligation is to stabilize or transfer. I love that slide. Okay, so here I have the definition of transfer, which is going to be important in a psychiatric situation, because what we see a lot of the times is an acute care hospital receiving a patient that doesn't have a psychiatric unit or the capability to treat a psychiatric patient. So the patient ends up being transferred to a psych facility. And the question for us is, when is a transfer appropriate? There we go. So not only does transfer have to be appropriate, but the patient has to request a transfer, or the physician has to sign a certification. So there's some general basic requirements, but ultimately our concern is going to be about when is transfer appropriate. So, receiving hospital, that would be our acute care hospital in our example, is supposed to provide treatment within its capacity to minimize the risks that the patient is going to deteriorate during the transfer. They have to call the receiving hospital, again, the psych hospital in our example, to make sure that they have space, qualified personnel to treat this patient, and that they agree. So they are supposed to call. And the transferring hospital, that acute care hospital, has to send all the documentation with the patient. Now this doesn't just include the medical directors, the medical records. In addition to the patient's regular medical records, the hospital number one, our acute care hospital, has to provide the name of a doctor if they refuse to come in. So if you have an on-call physician who refuses to come in, the hospital that's doing the transferring is obligated to tell the receiving hospital who that doctor is and the fact that he failed to come in. And that can trigger, on the receiving hospital's part, a reporting obligation that the transferring hospital violated EMTALA. Okay, more on when is transfer appropriate. Again, I've highlighted here the hospital with specialized capabilities can't refuse a patient if they have the capacity to treat. Now, something that's interesting for us and that we need to know about is that your capacity is not just your bed count necessarily. If you have customarily, historically expanded your bed count to accept more patients, let's say you got 5 insured patients that came in last month and you made room for them, the surveyors with an EMTALA survey will consider that and will consider whether you've customarily expanded your capacity when determining if you've refused someone inappropriately on the basis that you didn't have capacity to take care of them. So this is something to keep in mind when you're making a little extra room for some insured patients that have come your way. So how do EMTALA issues come up? On this next slide, hopefully you can see it okay, I have a picture that kind of gives you a graphic on exactly what happens. You can see right there we have a little guy with a blue folder under his arm, and it says complaint on it. EMTALA surveys are a complaint-driven process. So the complaint has to come in either from a patient that feels like they were dumped or didn't receive treatment fast enough or a screening or whatever, or it can also come from another hospital. The example I gave a little while ago about a physician whose name has to be turned over when he doesn't show up for call coverage, that complaint will trigger a survey. The complaint customarily goes to the state entity. Here it's our DHH. The DHH, the little guy with the complaint under his arm, works with the CMS regional office up in Dallas. The CMS regional office is really kind of calling the shots, and the DHH are the folks on the ground. You can see here I have the CMS regional office with the big road map that is provided by the State Operations Manual and the interpretive guidance. And I include these in your materials because I think it's really helpful to see exactly what CMS is telling the surveyors to go look for. You can be ready. You can know what they're going to be looking at. And that guidance gives a roadmap to the entire investigative process. I mentioned we have the instructions to the surveyor from CMS in that State Operations Manual. The very first thing the surveyors are supposed to do is to verify whether the hospital has an emergency department. Now, I mentioned a little while ago, there's that 1/3 test. It's not just, is there an emergency department? Are you licensed with an emergency department? The test is to look back and see in the prior 12 months, has that facility received 1/3 of its patients come in with an emergency medical condition who are ambulatory, don't have an appointment. That can trigger an EMTALA application. So be aware of that. Just because you don't have an emergency department doesn't mean EMTALA doesn't apply. So we have psych hospitals with this kind of issue. Another place we see this is perhaps OB units, where you have ladies come in ready to deliver to the OB unit at a hospital. Even though it's not the emergency department, EMTALA still applies right there. Okay, so if the surveyor determines that yes, you have an emergency department, EMTALA is going to apply. If it doesn't, then they're still going to expect the hospital to have appropriate policies to deal with emergencies. And our own DHH in Louisiana requires that all licensed hospitals have policies to deal with EMTALA. Now, what I have found acceptable historically, and what I know that DHH will take, is a policy that says the staff will be appropriately trained in life support. The person closest to the patient with the emergency medical condition will administer life-saving treatment. Somebody else will call 911, and you do the best you can within your capabilities to take care of the patient until the 911 folks get there. So that's generally how we handle that. Principal focus of the investigation is listed on this slide. As I mentioned, it's unannounced. It's going to be based on a complaint. And the surveyors are coming in to look at what actually happened, what happened with your patients, are the facts true. They'll be looking at your charts, and they'll be looking for a pattern. They'll be looking to see if there's a pattern of discrimination. And what can result from that is that they get back to the regional office and say, hey, we see discrimination based on something like race, nationality. Sometimes it's based on diagnosis like AIDS or pregnancy, psychiatric illness. So if they see discrimination against a certain kind of issue, like I mentioned, what can happen is the regional office will talk to OCR, the Office of Civil Rights, and then you'll have them at your doorstep. And trust me, it's no fun to have these people waiting for you when you get back from lunch. So another thing that can happen is if the surveyors, while they're there, identify a bunch of different problems, in addition to the EMTALA issue they're there to look at, they get in touch with our buddies at the regional office and say, gee, we think there are problems with the conditions of participation. We found, X problem. You mind if we expand the survey into a conditions of participation type thing? And CMS says, oh no, go for it. So the EMTALA violation, although it can seem small, particularly when the penalties are $50,000, it can really balloon into a major thing. So, and that's my next section. I mentioned the DHH stuff. This is our hospital licensing regulation. Okay, this section covers the latest from the OIG. Now, the OIG is the enforcement agency for EMTALA. CMS, the Center for Medicare and Medicaid Services, is the one that puts out the rules that we're all supposed to follow. And then the Office of Inspector General is kind of the hammer. What they have in their arsenal are penalties of $50,000 per violation, both for the hospital and for the physician. And this is actually less. If you have less than 100 beds, it's $25,000 per violation. Which, I mean, in the grand scheme of things, when you're looking at a RAC audit or self-disclosure, False Claims Act stuff, it doesn't sound like that much money. But in addition to those civil monetary penalties, you can be looking at exclusion. So that's like a death sentence. So OIG has some serious weapons in its arsenal to deal with people who are enforcement problems. And I have a couple of examples of some recent cases. This 2009 case was in California. It involved a man in his 80s who went to the emergency department with his family, and his family begged and begged the folks to take care of him. And they didn't. It went on 3 hours. He didn't get seen, he didn't get any help, and he died in the emergency room. So that's bad. They got the full $50,000 penalty, as you can see on my little cash there, and resulted in some publicity. And what the quote we got from Levinson in 2009 was that they intend to impose a maximum civil monetary penalty for egregious violations of the EMTALA requirements. And they thought that this was a great example of a really egregious violation. For mental health purposes, a recent case we may be interested in, for our purposes, was in Florida. And in that instance, the psychiatric hospital nurse got a call, picked up the phone, and there was a hospital wanting to transfer a psych patient over to her, and she said, "Does he have any insurance?" And they said no, and she said, "Then we don't want it," and refused to take the patient based on the lack of insurance. Clear violation. Here, they only got a $19,000 penalty, and the question is why? It doesn't seem like very much. We don't always get a lot of facts from the OIG. They kind of keep that stuff internally. There's a website where they list, some real basic blurbs on what went on. But what I've learned from listening to the OIG is that they take a bunch of things into account. So when you're negotiating with them, you really need to let them know all the facts. You really need to let your counsel know all the facts. In this case, I would suspect it was less than 100 beds, so the penalty was less. And I don't know what the exact facts were, but things that might have been mitigating would be things like this was a new nurse, she had just been there for 7 days, didn't know any better, and they fired her right after. Or they did a bunch to fix things right after it happened, or maybe the hospital was teetering on bankruptcy. The OIG, in a presentation I attended, actually indicated that one of the things that they will talk about or consider is if the hospital is really in dire financial straits. I mean, that's a mitigating factor apparently. So those are things worth knowing. So now I'm going to tell you a little bit about the latest from CMS. Now remember, OIG is the enforcement agency and CMS is the one who really puts out the rules. Now you'd be surprised, these two agencies don't really interconnect all that much. They both kind of do their own thing. So CMS are the rulemaking folks. Now in 2003, CMS came out with this bright line rule. And of course the lawyers and a lot of other folks were like, yay, we love bright line rules because it's easy. I mean, like, this is good, this is bad. And the bright line rule in 2003 was that EMTALA doesn't apply to inpatients. So patient comes to the ED with an emergency medical condition, hospital does the best it can to take care of them, admits them inpatient, and the EMTALA obligation is over. Now the conditions of participation still apply to take care of the patient, but ultimately you're done with EMTALA. So we love that, or I did, made my job easy. But the Tactical Advisory Group, which is a group of kind of muckety-mucks in the healthcare world, kind of got together and did a 30-month study on EMTALA. And what they went back to CMS with, among other things, was a recommendation that they give more guidance on this inpatient rule. So CMS figured, all right, that too, and we'll do it. They gave us more guidance in 2008. It wasn't very popular. Here's what they said. All right, so we have hospital number one. Hospital number one has the patient come in through the emergency department and admits that patient inpatient. Hospital number one's EMTALA obligation ends. But hospital number one needs to transfer that patient to hospital number two. And hospital number two has specialized capabilities to take care of that patient that hospital number one doesn't have. So, although hospital number one's EMTALA obligation is over, hospital number two still has an EMTALA obligation because the patient originally came in to hospital number one with an emergency medical condition. So people went bananas. They got all kinds of comments in response to this IPPS proposed rule in 2008. And CMS went, whoa, okay, we're not going to do it, calm down everybody. So what they did instead was in December 2010, they issued a request for comments and asked for more information to deal with these kind of instances, the type that I just described. You have the patient with the emergency medical condition that comes in, gets admitted as an inpatient at hospital number one for stabilization, and then needs transfer to another hospital with specialized capabilities. And this is particularly interesting to the folks in the mental health world because this can happen a lot. There is this delicate, challenging balance of patients with mental health issues where they come in and often there's a medical condition that goes along with the underlying psychiatric issue. Let's think of somebody with really kind of simply hit their head. You're dealing with the medical issue of do they have a subdural hematoma, and also you may be dealing with an underlying psychiatric issue based on the fact that what may have caused them to hit their head. Are they suicidal? Are they having delusions? Those kind of things. So the idea is if hospital number one gets the medical issue stabilized, we still have to deal with the psychiatric issue. That's where we see this kind of stuff come up often. So in this request for comments back in December 2010, we got this request from CMS saying, you know, this is the fact pattern we're looking for, and what we want to know from you is, should we revisit that policy about the bright line for hospital inpatients? And specifically, they wanted to hear about where there were inpatients transferred to a facility even though the admitting hospital could take care of them. And then also instances where a specialized hospital, like a psych hospital, refused to treat a patient where they didn't have an EMTALA obligation to take them. Also, they wanted just general opinions on whether folks think that hospitals with specialized capabilities, like psych hospitals, will accept these patients if they don't have that EMTALA obligation to do it. One of the places I see this get kind of thorny is when we're dealing with an uninsured patient, a homeless person, something like that. It can turn into a real game of hot potato. So I think there's a legitimate reason to look at this stuff. Ultimately, what has come of this is CMS gathered a bunch of comments between the deadline in February of 2011 and February of 2012. And generally the comments they've gotten on these issues is, we kind of like the way things are, we like the certainty of a bright line rule, while there are some issues, we think we should keep things the way they are. So that's kind of the approach CMS took. They issued some additional guidance in February of 2012, February 7th, February it was? Yeah, 2nd, February 2nd. So they said we're going to keep things the way they are, but they also asked for more comments. So they're still looking for information. We still may see some changes here, but for now it looks like we're going to stick with that bright line rule, which is nice in terms of certainty, but it's not so nice when you're a psych hospital who's received a patient with an emergency medical condition from an acute care hospital and they crash when they're in your psych hospital and have a medical condition, and the acute care hospital won't take it back, won't take the patient back. That's a scenario I had presented by one of the audience members in one of my recent talks, and it's a real problem. So I do think there's more for CMS to look at. The question is just, you know, what to do so that we have some certainty and so that we can address also some of the inequities. I have a few recent cases up here for you. The Moses versus Providence Hospital and Medical Center case. This is a psych case where a wife took her husband to the emergency department and he was suffering from some psychiatric symptoms, delusions, hallucinations, nausea and vomiting, and he was hostile to the staff. He was seen by 3 different doctors, including a psychiatrist who recommended that he be sent to the psychiatric unit. Well, instead of getting sent to the psych unit, he got sent home. He got discharged. And within about 10 days, he killed his wife. So bad case, ugly case. It shows up for us in the context of a motion for summary judgment. And one of the things that happened in that motion was that the doctor got dismissed. They said there was no cause of action against the individual physician. And the defendants, the hospital, was trying to say that there was not an emergency medical condition at the time. The court said, you know, we think there are facts that we need to explore in trial on that, so no motion for summary judgment there. Okay, so after the Moses case, we also have the Esperanza versus Sunrise Hospital case. And this goes to that medical malpractice standard of care issue versus the EMTALA issue that I was telling y'all about earlier. Here, they had a patient who came into the hospital with some psychiatric issues, and the hospital didn't have the capability to provide any kind of a mental health screening. So what they did with the patient is they put him in the observation unit while they waited for somebody to come over and do a mental health screening. Well, while the patient was in observation, the patient committed suicide. So the question was, for the court, was there a EMTALA violation or was there a medical malpractice issue, and were the two exclusive? The court, in looking at this, said that the hospital did the right thing in terms of EMTALA. They didn't have the appropriate people there to do the mental health screening. They put him in observation and tried to get somebody to come take care of him. But there is a remaining question as to whether the hospital reached the standard of care when the patient was in the psychiatric unit, under observation in the unit. So that wasn't resolved. This case was in the procedural posture of a motion for summary judgment. And while the court got rid of the EMTALA claim and said the hospital did the right thing there, they kept the medical malpractice claim going forward. A couple other cases, fairly recent on the mental health issues. I really like the Caristo case. There's no EMTALA violation where a doctor transfers a patient pursuant to a court order. You know, there was an allegation and a lawsuit that said the patient was dumped because the patient was sent from the hospital to another mental health facility pursuant to a court order. And it's like, yeah, that makes sense. Of course, the doctor would comply with the court order. That's not a dumping issue. And had it been decided the other way, you'd really put folks in a tough position. So I like that one. You get to do, you know, what the court says you have to do without risking an EMTALA violation. So the other case I have on this slide is the Centron case. And this is another one I like too. You can tell I like the ones where the facilities win. But here you have a patient who was suicidal and showed up after having ingested some pills, a lot of pills, at the emergency department at about 2 o'clock in the afternoon. And the hospital did some blood work on the patient, and it showed an elevated blood count, and ultimately the patient expired a little more than 6 hours after admission. The family came in and felt like they didn't treat the patient quickly enough, didn't take good care of the patient, and said that the patient was virtually dumped because the patient didn't receive enough care. And the court looked at this and said that the hospital didn't have actual knowledge of an emergency medical condition, that EMTALA requires that they actually know that there's an emergency medical condition and not treat it, not stabilize appropriately. So this, again, raises the question of the breach of the standard of care versus the EMTALA issue. And here I think we're dealing with a court that says, you know, no, we don't have a problem under EMTALA. They gave him a screening, gave him some tests, did that kind of thing. But I think the question that remains is whether the treatment they provided would breach the standard of care. And that goes to a medical malpractice kind of standard. Should the hospital have known? Did they mess up in terms of standard of care? Well, that's a medical malpractice issue rather than an EMTALA issue. So that's kind of what this case illustrates. So it's been fun. Thanks so much. And I've enjoyed telling you about EMTALA and mental health development.